So this is a normal routine case of phacoemulsification. So I'm basically a left-handed surgeon, but not left-handed exactly. I'm basically a ambidextrous surgeon. I use both my hands to do the surgery. Previously, I used to do rexes with my left hand, but the person who was teaching me, he asked me to start practicing with my right hand. So now I do rexes with my right hand, but phaco with my left hand. I mean, I hold the phaco probe with my left hand. So if you talk about rexes, so I do it with a cystitome, which is basically a 26 gauge needle. So this is me who is starting the raising the flap and continuing with the capsulorhexis. Previously, when I was learning phacoemulsification, although I have not learned it till now, also in a in a very perfect way, but previously when I used to do phacoemulsification, try to make a very large rexes so that in case if I have to convert, I can easily prolapse the nucleus from the capsular bag without any chance of capsular rupture or the posterior capsular rupture. But now I do a smaller rexes compared to the previous one. So after filling the chamber with viscoelastic, I make the main port entry with a 2.8 mm steel keratome. Previously, I used to hold the eye globe while making a keratome entry with the help of a limbs forceps, but later on I have realized that, and I have seen in many surgical videos that if you hold the globe with the help of a dialer or something, so there are very less chances of any conjunctival tear or any subconjunctival bleed. Although both the things they resolve with time, but on day one, if the patient sees a red colored eye, means he sees a subconjunctival hemorrhage, so he is very anxious ki what has happened to my eye, has the surgery gone wrong? Even if the cornea is clear, there is the lens is in the bag, but still the patient thinks like this. So now the next step is hydrodissection, which according to me is a very important step in phacoemulsification. It is very important that you should get an adequate hydrodissection, hydrodelineation, and a good rotation of the nucleus before um, entering with the phaco probe in the eye. If the nucleus does not rotate, it can cause a lot of problems during the surgery. So after ensuring that the nucleus is rotating properly, I have put viscoelastic inside the interior chamber, and I prefer to put it on the cornea as well because it enhances the visibility, and it also reduces the need to wet the cornea with the BSS or ringer lactate during the surgery. So now I'm entering the eye with my phaco probe. This is Ortlieb Cathrex 3 machine, which I'm using for for the past 3 to 4 years, and I'm very satisfied with this machine because with this machine I'm able to crack almost all the type of nucleus, like even if the nucleus is hard grade 4 or grade 5. So this machine takes care of all the type of cataract. So going on with the phaco 1 mode, I'm cleaning a bit of cortex and the epinucleus, and my preferred technique in most of the cases is a stop and chop. So in the phaco 1 mode, I'm making a trench. I try to make a deep trench in the first go only, so that the nucleus is divided into two pieces. What I've realized over these years is the most important thing is that your nucleus should rotate, and should divide in first go only. Otherwise you will create a bowl like structure which will cause problems, and you will not be able to emulsify the nucleus. And any attempt, if you take the phacoprov and move to the periphery, might lead to disastrous complications. Not in all the cases, but in some of the cases, it might lead to disastrous complications like posterior capsular rent, which almost every phacosurgeon or almost every cataract surgeon is afraid of. Now I have emulsified almost half of the nucleus, and I am continuing to emulsify the rest half of the heminucleus, or the heminuclei. So I buzz in with the in the phaco 3 mode, and then I go to the phaco 2 mode, hold the lens, hold the nucleus with the vacuum, and then I emulsify it. I like try doing it in the center, because there is more working space and there are less chances of posterior capsular dehiscence. So I've emulsified uh, almost the whole nucleus, and just the cortical matter is remaining. For cortex aspiration, my preferred mode is that I use a Simcoe cannula. Maybe because I'm used to of it for like so many years, so I don't use the bimanual or the coaxial irrigation aspiration. Although you should prefer a bimanual, but I do it with the Simcoe cannula. So what I do is that I try to pull it tangentially, not like in a direct line, so that you don't put any extra pressure or any extra thing on the zonules, and the cortex is easily taken care of. So slowly and surely I am removing I'm trying to remove all the cortical matter, so that the bag is clean. If you do a very good cortical wash and almost there is nothing in the bag, you will see that there are very less um, posterior capsular opacification cases in your OPD. But if there's a lot of cortical matter, or there is a plaque on the posterior capsule, so the patient will complain in the very initial post-op period only. Now a foldable hydrophobic intraocular lens is being implanted in the bag. Now this is a preloaded lens. This is Hoya iSert, so you don't have to load the lens. It's a very good lens. I mean, I implant this in many of my patients, and in most of them the post-op is good, the patient is satisfied. So after putting some more viscoelastic on the lens, I'm dialing it with the help of a Sinskey hook. One should always ensure that you have put the or you have implanted the posterior chamber intraocular lens into the bag. It should not be back sulcus, or it should not be in the sulcus if the posterior capsule is intact. If it is a rent, so that is another thing. So you will have to implant it anywhere in the sulcus, or maybe, but you should always try to implant the lens into the bag. Visco both from front and behind the lens is washed. Viscoelastic both in front and behind the lens is washed, and the anterior chamber is formed by hydrating the side port and the main port. Intracameral antibiotic. The preferred antibiotic of my choice is intracameral preservative free moxifloxacin. The intraocular pressure, or the AC formation is checked, and if the uh, anterior chamber the globe is formed. Then uh, subconjunctival antibiotics and steroid is injected in the